So I'm looking extremely forward to these presentations. Our first presenter is Lauren Sao. She's going to be speaking about factors associated with Korean American women's endorsement of HPV for their adolescent girls. So Ms. Sao, take it away.
Okay, here we go. My name is Lauren Sao, and I am presenting with my colleague Joylene Chepkorir on factors associated with HPV vaccination decision-making among Korean American mothers. Human papillomavirus, or HPV, is a pervasive sexually transmitted virus that is known to cause nearly all forms of cervical cancers and genital warts. In the past 2 decades, highly effective prophylactic HPV vaccinations have been developed that have led to significant drops in HPV and cervical cancer, with rates dropping by 86% for adolescent girls and by 71% for young women. With appropriate screening and completion of vaccine series, HPV and cervical cancer are very preventable, and cervical cancer is now considered one of the most preventable cancers because of the development of these measures. However, disparities in HPV infection and cervical cancer burden persist among ethnic minority groups, notably among Asian American and Pacific Islander women. Asian American adolescent males and females ages 13 through 15 had HPV vaccine completion rates of 41% and 60.1% respectively in 2020, which falls short of the Healthy People 2030 goal of an 80% completion rate for this age group. The population of focus for our study was Korean American women, who among 9 major Asian American and Pacific Islander groups have the 3rd highest cervical cancer burden, yet the lowest HPV vaccine rates. Current CDC guidelines state that the HPV vaccine is most effective at preventing infection when the series is initiated at ages 11 through 12. Because of this, parental or legal guardian consent is necessary in many states for adolescents to receive this vaccine. Parental reluctance towards HPV vaccination for their children has been well described in previous literature. However, to the best of our knowledge, only a handful of studies have explored this phenomenon among Korean American parents for their children. Consequently, for the purpose of this study, we decided to examine the factors that influence decision-making among Korean American women when making the decision to vaccinate their daughters against HPV, including demographic characteristics, cancer literacy, and HPV knowledge. We used the health literacy skills framework to guide our understanding of health behaviors and beliefs for this population. The Health Literacy Skills Framework, or HLS framework, was developed in 2012 to provide a unified and comprehensive definition of health literacy for health professionals. It postulates that the 4 dimensions of health literacy, which include print literacy, numeracy, comprehension, and information-seeking skills, are skills that can be developed, enhanced, refined, or even lost over time. Another assumption of the HLS framework is that demographic characteristics, individual resources, capabilities, and prior knowledge are interrelated factors that affect an individual's ability to acquire health literacy skills. For these reasons, we decided to include the demographic characteristics, cancer literacy, and HPV knowledge in our study on this population's decision-making for their daughters. And the third assumption of this framework is that health-related behaviors and outcomes have impacts on individual levels, systemic levels, and social levels in accordance with an ecological perspective. For our design of this study, this was a secondary analysis of data from a larger cluster randomized trial called the Better Breast and Cervical Cancer Control for Korean American Women. This was a health literacy focused intervention conducted from 2010 through 2014 to promote mammogram and Pap test screening among Korean American women. 560 participants were recruited by community health workers from 23 Korean ethnic churches in the Baltimore, Maryland, and Washington, D.C. metropolitan area.
This slide briefly describes cancer literacy and HPV knowledge measures used in the parent study. Cancer literacy was measured using the rapid estimate of adult literacy in medicine cancer tool, also called RIMC test. The internal consistency of this scale was 0.89, and it measured an individual's ability to pronounce 12 common medical words in the context of cervical cancer screening. A 12-item instrument with Cronbach's alpha reliability of 0.79 was used to measure attitudes towards HPV vaccination and HPV knowledge. Next slide. We used descriptive statistics to assess characteristics of the sample and multiple logistic regression analysis to identify the correlates of participants' endorsement of HPV vaccination. Next slide. These are the demographic characteristics of this sample. Age range was 21 to 64 years. All participants were born in Korea. 86% of participants were married or partnered, and 65% had some college education or higher. 67% reported unstable income at that time. 62% did not have health insurance, and 74% had limited English proficiency. Next slide. These are the results from the logistic regression analysis. Women with some college education or more had 40% lower odds of endorsing HPV vaccination for their daughters than those with high school or less education. Parents with medium level and high level HPV knowledge had significantly higher odds of endorsing HPV vaccination than those with low HPV knowledge after controlling for social demographic covariates. Korean American women with medium level cancer literacy had 1.7 times higher odds of endorsing HPV vaccination than those with low cancer literacy. Next slide. This figure shows reasons selected by 259 Korean American women who were either unwilling or uncertain as to whether they would allow their daughters to receive HPV vaccination. The two most frequently selected reasons were concern for unknown side effects of the vaccine, which was selected 148 times, and concern about effectiveness of the vaccine, which was selected 146 times. Next slide. In summary, here are the notable results from our analysis. It's not completely clear why women with high cancer literacy were less likely than those with low cancer literacy to endorse HPV vaccines for their daughters, even though the association was not statistically significant. It's possible that women with high cancer literacy may have had greater exposure to misleading information about side effects and efficacy of the vaccine, causing them to have had more misgivings about the vaccine, hence unlikely to endorse it for their daughters. A plausible theory in the literature that explains why educated parents were less likely to endorse HPV vaccination for their daughters is that highly educated women are usually able to easily access information regarding HPV vaccination on various media like internet, which could provide inconsistent information and cause women to be hesitant to endorse HPV vaccination for their daughters. Next slide. These are the implications of our findings. Clinicians should provide thorough education and address key concerns regarding HPV and HPV vaccination. Lauren, the previous slide. Sorry, they had that one, the one before. Clinicians should provide thorough education and address key findings regarding HPV and HPV vaccination among Korean American women during HPV vaccine counseling. Previous studies have shown that Korean American parents prefer healthcare providers as trustworthy sources of HPV-related information. Therefore, clinicians should take advantage of this trust that they have with these parents and give them the necessary education. It's also necessary to develop culturally appropriate parent and patient education materials on HPV and cervical cancer, including translating HPV vaccination education materials to ethnic languages that parents can understand. Finally, further research is needed to examine the relationship between demographics and HPV vaccine decision-making among Korean American parents. Thank you.
Thanks so much. We have about 4 minutes. I'm going to suggest, since we've got the 4 presentations and we've got 15 minutes for each, we've got a few minutes for questions if anyone's got any questions. Oh, and you might have already seen this question in the chat. In what ways do you think HPV is different? And you can probably read it faster than I can read it to you, versus the same as other vaccines, i.e. will the same be seen for COVID vaccine for kids? Just wondering. If one of the speakers wants to maybe address it.
I can't see the question.
So I'll just say it again though. In what way do you think HPV is different versus the same as other vaccines, i.e. will the same be seen for COVID vaccine for kids? It's in your chat feature too, in case you. Lauren, I know it's hard when we're all virtual, right?
Sure. I did think that this question would come up considering just how relevant the conversation on COVID vaccines and reasons for choosing not to vaccinate children is today. The population that we studied was specifically selected from Korean ethnic churches, and therefore it is hard to say. HPV vaccine has had its own history that is fraught with barriers. And I think there will be maybe some similarities with the COVID vaccine. In the past 2 decades, I'd say, we have seen a cultural shift in reasons that people have chosen for choosing against HPV vaccine. Previously, concern for promiscuity, such as my daughter will only have a limited number of partners, as well as fear that this vaccine would allow their daughters to have a sexual relationship. Those 2 reasons were previously top reasons against vaccination, whereas over the past 2 decades, it has shifted now, and concern more over unknown side effects and inability to believe the vaccine's effectiveness are now higher reasons in this population than the promiscuity reasons. So I wonder, that would be interesting research for the future, if these would be similar reasons for not getting the COVID vaccine. Yeah. Anything to add, Joy?
No, I think you addressed it well. Thank you.
Thank you so much. Great presentation. I think in the interest of time, we might move on because I don't want to fall behind. And if we have time at the end, I think we will have time for questions for all the presentations. But I'm thinking that we could move to Drenna Waldrop. And Dr. Waldrop is going to speak on relations among race, health literacy, and structural factors in healthcare to HIV viral load.
I'm going to try to. Let's see, are we working here? Yes, okay. Hi, good afternoon. Thank you all for the opportunity to present and for sticking with us after lunch. I know that can be tough. My name is Drenna Waldrop, and I'm a professor at Emory University in Atlanta. I'm the Assistant Dean for Research Operations and Training, and I'll be presenting this on behalf of my team and my my co-author, Dr. Ray Owenby. He and I have been doing this work for quite some time. So as you may know, HIV has made really tremendous gains in both prevention and treatment since the early 2000s, late just around the turn of the century there. Those gains, though, are not equally seen across the United States and in the US Deep South, which is the area of the country where I live. It has the highest diagnosis rate and the highest number of diagnosed cases of HIV still, even with adequate treatment, and HIV really being more of a chronic condition at this stage. Black Americans continue to be disproportionately impacted by HIV, and the US Deep South also has a large proportion of Black Americans compared to other areas of the country as well. So this is a very relevant area to do this work. And also low health literacy that in sort of our conceptualization is influenced by structural racism also continues and has been a part of the body of work that I've been doing over the years. So the purpose of this study, this comes from a grant that was funded by the National Institutes of Mental Health to look at health disparities in HIV clinical outcomes and health literacy, and some other contextual and social factors were also included in the grant. So the purpose of the study is to look at health literacy, race, and here we are really conceptualizing race as a representation of structural racism, not as a biological variable, and then other social and structural factors that may contribute to HIV health status. So this is the lovely city of Atlanta, which you may have seen if you were watching the World Series last night. Sadly, you won't see Atlanta again in the World Series. So in our study, we enrolled people living with HIV. They were recruited from 4 HIV outpatient clinics in Metro Atlanta. Metro Atlanta, for those of you who know anything about the city, is very spread out. So we required individuals to live within 30 miles of Atlanta to be eligible for the study. Just increased our participation rates, helping folks to be able to get into the city for the study visits, and also kept it much more of an urban population. Our study procedures took place between 2012 and 2017. There were multiple visits for this study. We'll just be looking at baseline study visit data today, and the data was collected in face-to-face interviews. Some of the questionnaires we used required some manipulation of objects, and so that was done sitting across from each other. Others were administered over an audio-assisted computer survey where the questions were answered on a computer screen. They had a headset for privacy, but there was always a research assistant available to answer questions. We also collected blood samples for our HIV viral load measures. And then we also collected data from the electronic medical records as well. So the measures that represent the variables of interest that we tested in our model are here. One of the measures we used was the HIV health literacy scale. This was developed by our team led by Dr. Owenby, and it's 19 items that are administered on a touch screen. Some of the elements include interpretation of prescription instructions. One of the things I really like about this measure is that there's a video encounter with a provider. So they sort of give you some information as if you're a patient, and then there are questions that you have to answer based on that sort of pretend encounter, which is really reflective of real world health literacy, and then other measures of medication taking skill. As you may know, stigma is a really big issue for people living with HIV and in the community. So we measured internalized HIV stigma. An example of one of the items is, I'm ashamed that I'm HIV positive. So some highly stigmatized items in this questionnaire. We looked at neighborhood characteristics. This scale included 7 items. An example is on your block, vacant housing is not a problem, somewhat of a problem, or a big problem. So we're trying to look at the community. We also looked at self-reported drug use in the last 6 months, cocaine use, marijuana, methamphetamines, opiates, or tranquilizers. We did do some urine drug screens prior to our study visits, and anyone who was, other than marijuana, anyone who was positive for any of these medications was rescheduled. In terms of health literacy, in addition to the health literacy scale, we were also interested in how well people are able to understand and manage their own HIV regimen. And so we used the drug regimen unassisted rating scale. This questionnaire sort of situates questions about your own HIV regimen, or any regimen that you choose to use for the scale, and has people answer questions about their prescriptions, the number of pills that they take, when they're supposed to take it, and any sort of special instructions along with that. We also measure discriminatory healthcare experiences. This is a 6-item scale that assesses HIV-specific discrimination as part of healthcare encounters and healthcare experiences. We looked at social support, an 8-item measure that looks at various types of social support. And for us, in this scale, we looked at available social support. So things like, do you have a ride? Can you borrow money? Do you have someone to talk to? Those sorts of items. As I mentioned, we took blood samples to measure HIV viral load. HIV viral load is a key indicator of HIV health status. As you may know, the less virus that's detectable in the blood, the healthier people are, first and foremost, and also the less likely they are to transmit the virus to others. It's a really key indicator of health status and will be used as our outcome. We also tried to, we used a measure of socioeconomic status, which can be a tough one to measure. And so a previous PhD student of mine, Ashley Anderson, and we published on a insurance status measure that looked at various measures of insurance as a proxy for socioeconomic status. So from Medicaid to private insurance. In HIV, there in the United States, there's the Ryan White program, which is sort of a program that catches those who don't qualify for Medicaid and don't have private insurance. And so there were some categorical variables that were created based on the permutations of insurance status that any individual had in the study. So here's a little bit about our sample. We had about half of our sample at 50 years of age. That's pretty common these days in, at least in our area in HIV research, as people are living long with HIV, they're aging with HIV, which is great to be able to say. And this representation of SES, we had a very low, and not low in terms of that socioeconomic status and insurance variable. We had so about 70% of our sample were men. We had a small proportion of transgender women in our study as well. For this particular study in the original development of the grant application, we were looking at race as a binary, Black versus non-Black. And we had about 60% of our sample who self-identified as Black. And that would include people who, if they identified as biracial, but sort of identified more as Black, they were also categorized that way per their own choice. Most of the non-Blacks were white. If anyone's interested, I can get more information about the breakdown of the other group. And then a little bit about drug use. Most of our sample had not recently been using drugs. This is the model that we tested. As you can see, it's a rather cumbersome model. And I want to thank Dr. Owenby very much for his help and support on this. And so a number of relationships that we're trying to understand, because as we all know, this is not a simple linear relationship that could possibly happen with all of these types of indicators in a model. And in trying to get the actual results on a slide was next to impossible. So you'll have to trust me when I go to this slide and give you the findings, okay? If anyone wants to see the actual numbers, I can get that to you. So as you can see, the final model did test multiple relationships that we represented in the figure. And we used the log viral load too, just because of the normality of the distribution. And for those variables that were associated with our primary outcome of HIV status, HIV health status, which was the log viral load, both, race, neighborhood characteristics, the socioeconomic variable, and then education were significantly associated with HIV health status measured as viral load. And marginally drug use and the HIV health literacy measure were associated with log viral load. But log viral load was not associated with HIV internalized stigma, social support, discriminatory healthcare experiences, and our measure of medication management. So some things to consider in this study. It was, for these particular analyses, this was a cross-sectional study at one site. Even though we did recruit from multiple clinics, it was still from one sort of general location in Metro Atlanta. And I just want to reiterate too, again, that as we are thinking about health disparities and I'm presenting my findings, that I'm not conceptualizing race as a biological variable, but more as a way to think about some of these social and structural and factors that we measured and that we've been learning about in the last several years. Some of the findings I think that are important to take home is that Structural and societal inequities are seeming to drive HIV health status. And I think that health literacy, so I sort of conceptualize it as an indicator for these systematic effects. These systematic effects of racism, and I think it really needs to be considered along with some additional structural indicators, as we heard earlier today, not just as a sort of an individual's issue, but a much larger societal issue, and in terms of health disparities, thinking in terms of systematic racism. And then I think I have a typo there. It's supposed to be may be needed, not needed. Structural and individual levels that target both interventions that target both structural and individual would be helpful, given what we've learned over the years about health literacy and what was presented here. And I want to thank my research team, my colleagues, my co-investigators, our study participants who've just been phenomenal, and the participation and cooperation of the HIV clinics here in the Atlanta area, and then for the funder, the National Institutes of Mental Health.
So Dr. Waldrop, super interesting study. I see a question. Do you think of health literacy as a social determinant of health?
Absolutely.
Yeah.
Yeah, I do. I think it's a double-edged sword, because as I conceptualize it, as I presented here, I think it's a big piece of neighborhood and education and access to resources and nutrition. And I'm a neuropsychologist, and those effects on the brain and that sort of thing. Where our challenge is in being able to measure it in such a way that it captures that complexity. And that's where I think we still have work to do.
Yeah, that makes sense. Anyway, thanks for a terrific presentation.
Thank you.
I'm just thinking, in light of time and making sure we finish on time, why don't we go to the next presentation, if Dr. Amoah is ready. So our next speaker is Dr. Padmore Amoah, and he'll be talking about examining the interplay of health literacy, healthcare access, and health service utilization, and their association with oral health status among older persons. Dr. Amoah.
I believe you're muted, sir.
Well, so I was muted, that's it. It's because I'm feeling sleepy, by the way. I'm in Hong Kong, so it's 2 a.m. right now. So thank you very much for having me. I want to share a bit about some research I'm doing, and well, with some other colleagues of mine. But before I go on, I'd like to say that everything I'm saying is part of an ongoing thought process, and all analysis are also in the same vein. So I'm trying to share briefly how the relationship between access to healthcare and then also health literacy and how they affect oral health outcome of older persons in places like Ghana. And I'm focusing on oral health specifically because it is considered as one of the challenging health situation in many developing countries. And in sub-Saharan Africa, or Africa in general, we see that around 400 million people are having or have situations or problems to do with oral health, not health literacy. And more, the problem mainly is older persons tend to suffer the brunt of this, because oral health is something that also sometimes get challenging with age, or it gets worse with age and others. So in places like Ghana, since about 2 decades ago, it has been identified that oral health is a challenge among older persons. But in terms of research and then also intervention to support this, it is still, I would say, at the formative stages in a way. So like I mentioned, I'm looking at how health literacy and access to healthcare can be considered as a fundamental determinant of this. So the question that Michael asked, the previous presenter, was quite brilliant. So it actually connects to what I'm saying here, because I consider health literacy and access to healthcare as fundamental determinants of health, and in this particular context, in terms of oral health. And what I mean by health literacy here, basically, I'm just referring to functional health literacy. So basically, I was looking at how issues of people understanding and being able to read health information and assessing them defines or affect their oral health. And in terms of access to healthcare, the focus here is mainly on issues to do with affordability. So I will show you later on about how I define it or how I operationalize it in my analysis. And the core point I'm trying to make here is that a better understanding of these sort of a situation, and especially the mechanism between them of how, for example, access to healthcare, health literacy interact and then also affect oral health, when we are able to understand this sort of relationship and the mechanism between them, it will help us to better initiate better and stronger intervention to support older persons who may or are likely to have oral health problems. So I'm looking at these elements as the potential interactive or factors that could affect the interaction between health literacy and oral health. So I'm talking about their general health literacy, their general health status. That means their general health condition, and then also the rate at which or the frequency at which they go for medical checkup. And then I also use access to healthcare as also an explanatory variable for the relation between access to health literacy, and oral health outcomes in a way. So in trying to understand this and read a lot of the literature, then I'm very pleased to see Michael here because he did this in 2007. And I really like this framework because it was maybe one of the first trying to theorize and providing a causative relation between health literacy and then various health outcomes. But for this particular study, I think that although Michael considers access to healthcare here, I also think that maybe if we put in, or maybe if we also consider issues of their health condition as it is, as we try to examine how health literacy affects other health-related outcomes, it will help us to better understand it. So just like I mentioned previously, I see health literacy and access to healthcare as a fundamental cause of health, oral health. So the question then I have to ask is then how do they work? And that is what I'm trying to examine using this model that I've been trying to develop in a way. So just like I said, it's still ongoing. So I'm looking at how these three variables serve as an intervening mechanism between oral health status and health literacy. But then I also look at access to healthcare as the determinant or maybe the independent variable between, and then looking at health status and medical checkup as the explanatory factors between access to healthcare and then oral health. So I try to test it out. And generally, as you can just see, I'm expecting very all sort of positive relationship between all these variables that I've tried to specify. And I took data from 2018 in Ghana, just collected primary data with the support of many very, very good volunteers. And we collected these data from about 2,000 people, but this is part of a bigger project. So the sample I'm actually analyzing today is a subset, and I'm analyzing people over 50 years and above. And we collected the data from, I think, 5 of the 10 regions. So Ghana has 10 administrative regions. So we collected the data from 5 of them as at that time, but now the administrative regions have changed. I don't want to speak more about it, the process of the methodology. If you want to find a bit more, you can read these pieces which were recently published, and we have also explained some of these methodologies. So how did we measure oral health? Briefly, we just asked one question: how would you rate your oral health status? Similar to the general question we asked about general health outcomes. So people would answer from 1 to 5. And then health literacy, I used the one adapted in Sweden previously, measuring about functional health literacy. So we asked about 5 different questions or 5 items, which are measured on 5-point Likert scale. So an example, do you find it difficult, or do you think it's difficult to understand words and numbers relating to health information? And then also access to healthcare. What I mentioned was that I was focusing mainly on the financial aspect of it. So people call it the affordability of it. So the question was about whether people had a situation where they couldn't afford their health service because they could not pay for it in a way. And then they'll rate their outcomes or maybe their responses on a 4-point Likert scale. And then we also asked them whether they have had voluntarily went for medical checkup without a doctor's recommendation. I think the slides moved out a bit. Sorry about that. So this one, they also answer yes or no. And then their general health status, we also asked them the general question about overall, how do they also look at or feel about their general health status in a way. So the sample includes about 54% of male, and the issue is we collected the data sometimes from places where there was male-dominated society, so they will require the male to speak on behalf of families because this was a household-based survey, and the age we had around 61 or maybe 62 on the average, and with as old as 91 years in it. The general education status, I think I provided it twice here, but then the general education status, you see that about close to 40% of the people had never been to school in a way, and then majority of them has had, not majority actually, very small proportion, just about 7% had had tertiary or postgraduate education. And when it comes to access to healthcare, when you ask the question about their financial issue, about 59% said they never, but then we also have quite a significant amount saying it happens, but not often, and others. In terms of their health literacy, was quite low, around 46%. And just about 40% of them claimed that they had voluntarily sought for medical, preventive medical checkup without a doctor's advice, or they themselves making the initiative in a way. And in terms of their general health, we realized that it was just generally fair in terms of how they rated it. So what is found here is that the key components of health literacy as their general health status, and then also their medical checkup behaviors were all related to their oral health literacy status, but then access to healthcare did not actually. And I tried to look at some mediations between this, as I mentioned earlier on, and we realized that there was indeed a mediation of health literacy between there was a mediation of health status between health literacy and then oral health status among these particular groups. So that was the first thing that we observed. And the second thing I observed was that their health status, their general health status also mediated their relation between their access to healthcare and then their oral health status as well. And the final thing was also to examine how their behaviors in terms of medical checkup also whether they could mediate the relation between access to healthcare and oral health status. And we found that, yes, indeed, there was that mediation between of medical checkup between access to healthcare and then oral health status. But then I went a bit further to check, and I did that for all the relationship that I actually examined, but only this one proved significant, that there was a significant difference between males and female when it comes to the extent or how medical checkup mediated the relation between access to healthcare and then oral health. So that means there's some gender issue to consider there when we think about this sort of analysis. And so finally, I'm trying to still wrap my head around many of these things. And what I would like to say is that oral health outcomes of older persons may be affected by their health literacy, but then the state of their overall health may rather help us to understand better how health literacy is related to oral health. And then in terms of access to healthcare, I also saw that it influences oral health outcome, but then it is explained by the overall health status. And I'm arguing here that perhaps maybe oral healthcare is sought as part of other health conditions. That is a secondary complaint that people make when they visit the doctor or they want to see a professional. And also medical health checkup explain the association between access to healthcare and oral health. So what I'm saying here is that maybe having access to healthcare may not necessarily lead to a better oral health status, rather being proactive if the person is proactive. So maybe we may be talking about issues of self-efficacy and others. Though that sort of behavior or that sort of inherent or innate behavior could help people to be proactive in utilizing available health services. So it may not be just the health services available per se. And financial barriers to seeking preventive healthcare may be more challenging for females, as the evidence seems to suggest. And it tends to maybe correlate with the overall socioeconomic dynamics of the country, where you realize that males tend to be more financially secured compared to females. So this may be actually explaining or supporting that sort of general dynamic of the socioeconomic environment. So finally, what I would like to share is that maybe as part of efforts to improve oral health of older persons, we might need to consider the interplay of these kinds of variables in terms of their health literacy, their access to healthcare, and other behavior and issues that could potentially affect people's older persons' oral healthcare, oral health status. Yes, thank you very much. Thank God I didn't sleep.
Sorry, just trying to unmute myself. Great presentation. I'm also very glad you stayed awake, but I had a feeling you would. So you might see that comment on the side, and I'll just read it out. Oral health, this is from Michael, is hard to measure by self-report, as there commonly is fatalism, if I pronounce that word right, about dental outcomes that vary by socioeconomic status. That is, if you just expect to lose all of your teeth, then you may not rate your dental health poorly, even if you have lost all your teeth. And then he's asking your thoughts on how the model may have influenced if you had a dental exam instead of self-report. And you're on mute, sorry.
Oh, thank you very much, Michael, for your question. I totally agree with you, but this was a social survey, and as you realize, all the other indicators are also self-reported in a way. So we are dealing with, let's say, apples and apples in a way. So, but then I certainly agree with you that with a clinical measure, we would probably get something much better results in a way. But what we did in the survey was that I think I didn't pronounce, provided a definition. So as part of the questionnaire, we had, I couldn't mention it, but we had people conducting the survey for us. So the trained interviews will ask the people not just to read their oral health status, but then they'll give them examples of what could mean, whether they have pain or whether they've seen a doctor before about it, and different kinds of potentially situation that could be clinically diagnosed in a way. So of course it's clinical, it's self-reported, but we try to get people's minds towards what they could have experienced in the past year or two in a way. So that is how we measured it. But I certainly agree with you about how clinical aspect could have also affected this in a way. Thank you.
Just to follow it up, I think it may be that your model is underestimating the impact because of this phenomenon, you know. But that's how I would hypothesize the influence of this. Yeah.
You're actually right, because if you look at, you are definitely right. If I look at some of the relationship in terms of, these are all standardized variables. So if I look at the value of the strength of the relationship, I think definitely if it was measured from a clinical perspective, I would certainly have a much stronger relationship than I'm observing in a way. So I agree with you. Thank you.
Dr. Amoah, we only have 1 minute left, but I'm going to throw in a question. That significant difference between males and females, do you think it was largely the financial barriers, or did you think it was any other factors?
I think for the evidence I have, I think it's financial barrier, because the question I asked for access to healthcare was financial, right? Whether they have had situation where they could not access healthcare because of financial issue. So they had to put it, hold on. And then the mediator here is also about medical checkup. So if you put these two together, it means that even if a person wished to do it, maybe the financial issue might be a problem in a way. But certainly we can also consider other factors. And I would agree that issues of, for example, awareness, knowledge, and then again, we can go back to the health system itself. If I go back to Michael's framework, the extent of access to healthcare, other factors of access to healthcare, like maybe the acceptability of the services that is available, and even if there's available clinical care for that, because many of these sample were in rural areas. So there's a very high likelihood that many of them could not have access to a trained medical professional in the field of oral health in a way. So it's likely there are other factors, but I'm conjecturing here that maybe financial aspect because of how the variables were measured. But yeah, thank you very much.
Thanks so much. Great presentation. So our last speaker is Andrea Morrison, who's going to be speaking to us about asthma education for high-risk patients, decreases acute healthcare utilization for asthma. Dr. Morrison.
Thank you very much. I apologize that I'm not going to show my video just to save bandwidth for the presentation. So thanks, I'm happy to be here from Medical College of Wisconsin and Children's Wisconsin in Milwaukee. So asthma is the most common chronic illness of childhood, and 1 in 12 children have asthma across the country. Children with asthma frequently use health, and 5 children with asthma coming to the emergency department each year. At our hospital emergency department, we see 6,000 asthma exacerbation patients each year, and in our hospital, we hospitalize 400 children each year. Children are more at risk for those increased healthcare visits if parents have received no asthma education, and also if the parent has low health literacy. So parents with low health literacy, their children have 40% more ED visits and 460% more hospitalizations if they have low health literacy. We know, and I'm speaking to the choir here, that low literacy teaching methods are very effective, and specifically in asthma in childhood, as teaching with low literacy methods can reduce future ED visits and hospitalizations. And this works also for individuals, especially with low health literacy. So one factor that has been missing is a system-wide distribution of asthma education, especially with a low literacy focus. So the question is, does health literacy focused asthma education given to families of children seeking acute care for asthma decrease return visits to the ED or hospital for asthma exacerbations? This was a retrospective analysis of the outcome data from a quality improvement project, which aim was to increase health literacy focused asthma education distribution. The citation for that paper is below. Patients in this retrospective analysis were seen in the emergency department or hospitalized for an asthma exacerbation, and they were aged 2 to 18 years of age. The health literacy focused asthma education was described in detail in that last article that I showed. But what we did was we used NHLBI content recommendations, used a large work group of individuals from across our health system, including our patient education experts. We did initial needs assessment with parents, as well as parents throughout the development, reviewed the education throughout the development, and our final product was reviewed by our Patient Family Information and Education Council. We developed low literacy content, including handouts with specifically images that matched the videos and what parents would see in the videos. We developed the videos, and then a notebook was a compilation of all of the handouts together. We contracted the videos and those images from Booster Shop Media. You can see to the right a demonstration of our written material. We use principles, health literacy principles such as limiting information, explicit and action-oriented instructions, chunking, plain language, white space. We did have these available in English and Spanish. Spanish is about 5% of our patient population. We limited it to 1 to 2 pages per each section. The notebook contained all of those notes, all of those pages, as well as notes pages for parents to take notes at times when they needed to. The video information did provide demonstration for families, specifically in asthma. Using a metered dose inhaler is complicated, and it also varies by child age. And so we wanted to make sure that that was well demonstrated for families, as well as things like asthma physiology and exam findings, or what parents might be looking for when their child is sick. There was syncing of the language between the written information and the videos. We did did education to our nurse physicians, APPs, about how to speak verbally to families using a literacy-focused approach. Specifically, we discussed and using open-ended questions, teach back, and we had specific teach back questions for each of our video modules, plain language and limiting information, as well as providing action-oriented information. So this is just a very brief overview of the quality improvement project. The emergency department initial PDSA cycle was May of 2018. In August, we finished with our final PDSA cycle in the emergency department. February 2019 was the initial cycle in inpatient, and July 2019 was the final PDSA cycle. What we did during this was to increase the distribution of our asthma education. We did find in the emergency department that written information went from 20% of parents and children to 52%, video from 0 to 32%. In the hospital, written information was not distributed any more frequently. And in the hospital, video went from 0% to 42%. The outcome measures that we will evaluate in this analysis include ED visits and hospitalizations 365 days following the index ED visit or hospitalization, and visits are for primary or secondary diagnoses of asthma. The statistical analysis we compiled and used descriptive statistics for demographic data. We compared groups with or without educational intervention, separately written and video, with generalized estimating equations for data from January 1st, 2017 to April 1st, 2020. We did have, unfortunately, some effect on our data from the COVID pandemic on the asthma visits. Specifically, stay-at-home orders, other pandemic restrictions actually reduced our asthma exacerbations in children. And so we truncated the visits so that the follow-up visits ended at the end of March 2020. So we avoided any of that decrease in visits that was actually due to some of those other environmental factors. Here is just a brief table of the demographics. Now, these demographics are reported from our electronic health record. We analyzed 4,855 visits for 3,000 patients. And you can see the distribution of 61% male. We did have 37% white, 60% Black, and 15% Hispanic. And 5% of our population preferred another language than English, and 74% had public insurance. Low health literacy, we use the CHEW question in the emergency department and hospital and is asked in about 90% of our patients and families, and 13% scored as low health literacy on that question. We broke down the demographic data just by whether or not they received video or did not, because that was both in the hospital and in emergency department did increase. There were no differences in demographic variables between those two groups, except for in the group where there was a significant difference between whether or not an individual received the video, with those that speak a language other than English did not receive the video more than they did from just the baseline data. First, we're going to look across any index visit type, so whether they come to the emergency department or hospital for that first visit where they receive the education. So the effect of written education on return visits, children were less likely to have return hospitalization with an odds ratio of 0.8 if they received written education at that first visit. Now this, I'm going to break this down by 3 different outcome variables in this: whether or not the child return visit was to the ED or hospital, ED only, or hospitalized on that return visit. On the x-axis is a log scale with an estimate, the point estimate being a circle of odds ratio, and the horizontal bar indicates the 95% confidence interval. If that bar crosses 1, that means that the result is not significant. So we can see here across all of these return visit possibilities, children have less return visits in the year following if a parent received the video asthma education. We're going to look at that similar type of graph if the child was in the ED for that index visit. And again, we found that children have less return visits in 1 year. And now this is for the written instructions. It's across all of those return visit types that we have a significantly decreased number of return visits. And again, for the parent, if the child received, parent and child received the video in the emergency department, they again in the following year had a reduced odds of having a return visit to the ED or hospital, ED alone, or hospitalization. So limitations of this study include that this is a quality improvement study. We were unable to assess actual measured asthma knowledge either from the parent or the child. And of course, there may be other factors we did not measure that are influencing those decrease in return visits. We did try to take out the COVID pandemic interference in the data by truncating the data after the point of the pandemic. So we found that asthma education given to parents at the point of an acute asthma visit is effective, specifically to reduce future healthcare use for asthma exacerbations. And this was done on an organizational scale, and we've shown that this is a possibility that can be done. The interesting ideas about future directions for this, we thought that an ED visit or a hospitalization for acute disease exacerbation seems to be an opportune time for a health literacy focused intervention. And it impacts those high risk populations that only come to the emergency department or are hospitalized and may not follow up for those other appointments. And so we may be reaching that population, and that's why it's so effective, or perhaps because it's very salient to them at that time because their child is having difficulty breathing. So more to come with further thoughts about that, but we are continuing to implement in our asthma, allergy, immunology, pulmonary clinics, 6 urgent care sites, and eventually our 26 primary care sites. And I'll be happy to talk about more data once we look across our whole population. So I'd like to acknowledge the large number of people that were involved in this body of work over a number of years. And I'm happy to answer any questions. Thank you.
Thanks so much. So we have time for questions, and we also have a few minutes. So we have, well, we have 4 minutes, but if people have questions about other presentations too, we have time as well. And Andrea, you could probably see this, but there have been multiple, Michael's question, there have been multiple reports of race disparities in asthma outcomes. And just asking, have you looked at the impact of your project on that?
So, you know what, rather than trying to bring up slides, we've looked at it from the quality improvement perspective thus far, but we will be adjusting for that in the analysis as well. But we did look at both those that received the videos were equal across white, Black, and Hispanic. And then also the outcomes, we did find a reduction when looking at it from a quality improvement perspective. We did find a reduction across race, ethnicities over time as well. And so we will be adding that into our analysis to hopefully help help the understanding of what the outcomes actually are that we found.
And Andrea, there's another question from Shani Yin. Did you look at the impacts of receiving both the written and video educational materials? Can you talk about how receipt of written video use was tracked? Was it automatically logged, or did providers self-report use? You can probably see her question too. Okay.
Yeah, I just pulled up the Q&A. Great question, okay, Shauna. Good. So we did, in some of the analyses, look at whether they received any, and we did that as just as part of the quality improvement project, and found equivalent outcomes. We haven't done that as part of this analysis, but I think that's a great way to think about it for some additional analysis that we could do. And Shauna points out some of the real difficulties with real world implementation, which is how do we actually track these? So the data that we have from this project does come from our electronic health record. The method that it actually gets put into the electronic health record is in the nursing documentation of education. And so, we only can pull what somebody documents. Hopefully in the future, we are actually going to have a program that we can have specifically prescribe information to people and then actually get back whether or not they watched it and how long they watched it. But right now, it's just based on whether or not a nurse has clicked that they did receive the information.
And let's do one more question. Were the patient's families also able to review the videos at home or only in the hospital? Were you able to track how often they reviewed?
Yeah, thanks for that, Jerry. So we did have this available on our website. Unfortunately, it was password protected just due to the limitations of our contract. However, changed now in the future, but we did provide that password on all of our discharge instructions from the ED and hospital. So I agree, having that follow-up at home and the ability to not only have the written information we give them, but then have that video follow-up at home is really important to solidify that. So we wanted to make sure that it was available to parents. One other thing that we've done actually is we're now going to start texting it as well once our contract changes a little bit. So we'll be able to more directly send it to people. But we are, other than a gross number of individuals that went to the website, we're not able to track specifically how many individuals that we gave that to link to actually went to that link.
Andrea, thanks so much for your presentation. I hate to stop the questions now, but I think we're going to take a little break before we go to our next session.
Well, it's actually starting right now. So thank you, everybody. Really appreciate it. People even staying up in the middle of the night. It's great presentations. I'm sorry we didn't have more time, but please join us in the next room. That's the room where we have 2 options. So hope to see you there. Well done, everybody. Thank you.